You're fine.
Excellent. All right, we are live. Hi, everyone. I'm Michael Corslin with Manifold Group and Lots of Helping Hands. Welcome to the June edition of the Healthcare Pulse speaker series. Today's topic is a new era for Medicaid, harnessing innovation for transformative care. I'm so excited about the topic, given recent work we've been doing within Lots of Helping Hands to help family caregivers access a broader set of healthcare benefits when caring for loved ones. But that being said, I'm even more excited to introduce you to our very special guest, the founder and executive director of Health Tech for Medicaid, straight from California, Adamika Arthur. Adamika, thank you so much for joining us today.
Absolutely. I'm glad to be here.
Pleasure to have you. Now, just so everyone knows, Adamika and I met at ViVE, the ViVE Healthcare Conference in Nashville this past March. She was leading a 2-hour session on Medicaid innovation. And it was the best conference session I've ever attended. It was fabulous. There was a series of roundtables amongst Medicaid space innovators, entrepreneurs, investors, et cetera. It was fantastic. For those of you who haven't had the pleasure to meet Adamika yet, I'll give you a quick background, and then Adamika would love for you to fill in any gaps here. But Adamika is an absolute superstar within the space. She's affectionately known as Madam Medicaid for being able to turn any conversation into one about Medicaid and the innovation around it. By training, she's a clinical epidemiologist and a successful healthcare administrator with a proven record of developing innovative strategies to help improve the healthcare triple aim. In Adamika and Health Tech for Medicaid's mission to serve the most vulnerable populations in the country, she also, like one of the coolest things, she also brings together a range of stakeholders. And I'll just mention a few, and Adamika, you can add to this list, obviously, but She's bringing together state governors, secretaries of health, venture capitalists, other investors, entrepreneurs, et cetera, all to discuss and solve the real problems that are impacting Medicaid enrollees today and the networks that support them. So Adamika, thank you again so much for joining us today. I know you're extremely busy. Would you mind kicking us off by sharing a little bit more about Health Tech for Medicaid, its mission, the Medicaid population it supports, and what inspired you to start it?
Sure. That's a mouthful, but I will do my very best. How about that?
We can chop it up. Yep.
We see Health Tech for Medicaid as a game changer, kind of in the pursuit for equitable care for all. We are convener, and we started that way really because our mission is quite clear. It's really to support innovation in Medicaid, and that's to improve the quality, equity, and access to care, mainly for the millions. I mean, there was 94.1 million people on Medicaid as of the latter part of last year. We'll talk later about the almost 650,000 who have dropped off the Medicaid rolls since April 1st due to Medicaid redetermination. But there's millions of individuals on Medicaid, and there's also millions of people that actually support them as caregivers, not only parents, but true caregivers. So it's a huge bolus of, it's the largest insured population in this country, and really makes up the undergirding of our society. For me in California, and I've lived here and deeply impacted in the Medicaid program here for the last 20 years. But for me in California, it's over 1 in 3 people who live in California. So that just gives you the depth and breadth of who. So we see this as people who are recipients, they're caregivers, they are family members, and ultimately that makes up all of our communities. So Health Tech for Medicaid really stands at the forefront of a movement, really, that addresses kind of longstanding disparities. We've talked a lot about health inequities in healthcare for many years, as long as I've been in healthcare, which is almost 30 years now. I hate to say it like that, but we regularly talk about leveraging the power of technology and collaboration, and that's essentially what we do. So Health Tech for Medicaid has innovative programs, cross-sector partnerships. We do a lot of policy advocacy to accelerate the pace of change in Medicaid, ensuring kind of nobody's left behind. And so it really falls on what I would say 2 core principles. One is the principle of equitable and inclusive design, and that is of products, services, delivery systems, ultimately capital markets and narrative change. And also around just the basics of universality and universal design, and that we can design things and have done a very good job of that where it benefits the most people without much thought around how that is done. And so I guess the universal design concept we often talk about is the great public health example of the universal design feature of a curb cut, right, in in a crosswalk. In 90% of America, in any kind of incorporated area, you can cross the street. And that's really important if you have young children, or you're non-ambulatory, or you're in a wheelchair, or you're deaf or blind, right? But none of us really think about it. We just kind of can cross the street, and there's bigger bells and whistles as you go along. So one of the misnomers is that Health Tech for Medicaid is all about technology. We don't believe that technology is the sole answer, but we believe that Health Tech for Medicaid is really more than a business, right? It's a force for social change. We kind of say we're at the point where health equity and tech equity come together. So to answer the question about how this started, how my interest came and peaked in this area, I think, as you mentioned earlier, I'm an epidemiologist. The first portion of my career was really in traditional public health work. And so I think understanding and learning about health disparities, how that impacts communities, and how that impacts quality and duration of life was really important, fundamental background for me. I got to Medicaid in a very strange way in some cases. I worked for a county health department, and then spent some time looking at how we could improve care in California, specifically in Alameda County, which is the 7th largest county in California, 25th largest county in the country. Very diverse county. It's large. It has rural areas, urban areas, large cities, very small unincorporated areas. So is somewhat representative of a coastal city, I will say, on the coasts. But what we learned through that was really the way that we could impact care was through the delivery system itself. And through the delivery system, it really meant about how do we better reimburse care in an innovative way. That turned into an 1115 waiver in 2005, which changed the state of California, to be fair, and actually ultimately kind of changed the way we look at things in the U.S. That was a Medicaid expansion in 2005. That got about $180 million of federal money, got drawn down over 3 years, and was given to 10 counties in California to be a demonstration project. Alameda County was one of those counties. And I had the unique and amazing fortune of realizing that the delivery system was the way in. And so I actually changed my career from being an epidemiologist to being a hospital leader. And I will say that was with great reverence and people looking at me with the ability to learn. And I think just my deep passion for improving this system for people that look like me, people that are like my parents or my children, or, ultimately in the community in general. So I did this with a really heartfelt space first, and learning, obviously came second. I've always had what I consider to be a learner's mindset. And trying to ask questions. That turned into almost a 15-year career in running hospitals, from public hospital to large academic medical center to large not-for-profit system with a $30 billion infrastructure and budget. And through that learning, I think, I kind of realized the delivery system wasn't always the answer, but it took a lot of study and really understanding. And there was this brand new field called health technology, which had just kind of creeped on the scene about 10 years earlier, about 5 years ago. And I was very interested in what did that actually mean for us as hospital leaders. For us, we were thinking about, computer software projects, and things like electronic health records became very sexy. But I had no idea that they were actually starting to have entrepreneurs design and develop products that could save people's lives. And that's where the kind of convergence came together. That like if folks running systems have no idea what's happening in this brand new field, how do we actually coalesce this brand new field, which was called health technology, but ultimately to me looked like just technology. It didn't have competencies or a Hippocratic oath like weaved into it. And so really this was a braiding and a marrying of how do we take populations that are in government programs who are often not seen as a good customer, but make up a huge bolus of the U.S. economy. And if health is our largest economic indicator, right, how could we work together collaboratively to save more lives? And so that's the kind of origin story of Health Tech for Medicaid and how we came to be.
Thank you so much, Admika. I mean, it's such an inspiring story. And you mentioned that delivery is the answer, if I heard you correct. And that was one of the things that prompted you into the space from epidemiology itself. You also mentioned, I guess the impetus that led you from healthcare administration to health tech for Medicaid was just there's a gap that you would like to bridge between the technology that exists that can save lives and the delivery system. Could we dig into that just a little bit?
Sure.
For example, would you mind pointing out any specific examples that come to mind in terms of here's a problem for the Medicaid population that you've seen in the past, and a technology solution that maybe wasn't, I guess, adopted within the delivery system yet, and how?
Sure. I mean, there's millions of those examples, and I think that's why health tech for Medicaid exists. So what I will say is, in the beginning, as a public health professional, you think of the continuum between where prevention all the way to treatment kind of is, right? And to me, what I saw as an answer in saving many of our health disparities really fell in line with we could do prevention all day long, but if we don't give people access to treatment and care, right, we weren't going to get anywhere, right? And so that's where I really thought the delivery system was a great place for me to actually solve problems and challenges. What I learned in starting health tech for Medicaid is we have all of these stakeholders. You talked earlier, right? We have payers, we have providers, we have regulators, we have policymakers, right? We have advocates, and then we have the general population. And I mentioned earlier that 1 in 3 Californians, a little bit over that actually, are on Medi-Cal, which is the Medicaid program in California. And I'll talk a little bit about the state and federal inklings and why, because I think it answers your question. In the US, it's a little bit more than 1 in a 5th Americans, right, are on this program. So that's a huge chunk of our society. It does change by state. It does change. And Medicaid is a federal program, but it's a federal and state partnership. So we have 2 big federal programs, right? One is Medicare, which generally you have to be over 65. There are also people that are on both programs. They're called dual eligibles. But Medicaid itself is a state and federal alignment program, which means that the federal government kind of creates the floor, right? The basic benefits. And then on or the roof or the accoutrement that come on the rest of the house is really the state. And so it does matter where you live. Now, to be fair, what also matters where you live is your life expectancy, right? So we know that your zip code actually can define and kind of infer how long you will live, which for many people is quite shocking, but is actually true. We've known this in public health for a little over 30 years. So these place-based strategies are also equally important. So when you ask the question around where has technology actually mattered? There's a lot of places where it mattered. But what we like to do is think about the actual disparity first, or the population, right? And then reverse engineer what technologies do we have? Who's using them? How is it working? Where is it working? I'll give you a great example, which I think is, maybe it's a little volatile example in the US right now, but sexual reproductive maternal health, right? It's a big area. 53% of the births in this country are Medicaid births. Most people don't know that. That's more than half of Americans are born on this program. Now, to be fair, Medicaid is 57 years old. And there's all sorts of really interesting and great historical references about how Medicaid came to be, what it has done to give lots of people access to care. But even a 57-year-old program needs some tooling and tuning, right? And this is certainly one. It started out as kind of a women and children's program from the very beginning, first 23, 27 or so years, right? And so when you look at that, you think, wow, we should have made some massive advances, right? In, how babies are born, infant mortality, maternal mortality. But actually, if you look deeply, we've actually gotten worse, right? So we're spending a lot more money, and worse in certain populations of people. And this is why disaggregated data is important. It's also why a convening body coming around an issue is important, right? So there are lots of different types of innovative solutions for sexual reproductive maternal health. But if you looked 10 years ago, there was one very little, and there was certainly very little with lived experience. Women who actually are creating businesses because of their own personal experience, people that are creating solutions because they see that we need promotoras or doulas or, so this is an entree way into impacting the delivery system, right? And the entire continuum from prevention to treatment. And that's why Health Tech for Medicaid is really important, because the reality is venture capitalists speak their own language, and they talk to investment bankers. They maybe talk to PE folks. They rarely talk to, entrepreneurs, right? Unless they're investing in their business, right? Entrepreneurs rarely talk to delivery system folks. In fact, they only talk to delivery system folks when they want to get their product sold, right? And so how do we get the business intelligence of what's on the ground? What are the hospitals and care clinics and care delivery systems seeing, right? How is it that payers know what they're paying for and what those outcomes are? And we've talked about value-based care for probably a good, my whole career, right? We've been moving towards value-based care. But the reality is we spend a whole bunch of money and we're not getting the best outcomes. And so technology is a way for us to actually disaggregate that data, come back, figure out how we can actually make things happen. Now, look, it comes in the fact that we are the United States of America. We're a very big country that's wholeheartedly deeply diverse, right? And there are political and business acumen components that impact that. But before Health Tech for Medicaid existed, we really didn't have a place where these conversations were interrogated well.
Interesting. Thanks for sharing the the maternal health example, Adamika. And I know another one that is near and dear to Health Tech for Medicaid's mission is redetermination. And you've put a few of these webinars on over the last few months, and I've been fortunate enough to attend a couple of them and look forward to attending more in the future. But and suggest it to any audience members as well. It's fantastic. It points out a very specific problem, a big problem, given the public health emergency unwind and the reduction in Medicaid rolls as a result. And I know you mentioned earlier, Adamika, that something over 600,000 individuals have already lost coverage.
Yeah, there was a KFF report that recently just came out. So let me just back up and explain why redetermination is important. So one, part of the reason why Health Tech for Medicaid exists is to dispel myths, right? Is to really give people information. It is really hard, excuse me, to best understand Medicaid. So I kind of mentioned in the beginning, Medicaid's done 56 different ways in this country because each state, territory, district have their own program, right? We've got the general federal program and then all the things that go on top, right? We have expanded states and non-expanded states. We have, and partially because it's paid for by taxpayer dollars. So if you think about it, it's a double taxpayer dip, right? You've got a federal program that all of us pay into, and then you've got a state program that folks pay into. So truly through your state legislature and your governor and your system, care is thought of differently. So if you live in certain parts of the country, there may be very different types of services that are needed based upon the demographics that live in your state, the things that people care the most about, the type of things that happen. So if you're in middle America and farm injuries are really high, there might be a large focus on disability, right? Not from just birth, but also from accidents and injuries, et cetera. Those folks are all serviced by Medicaid, right? So I guess the best way to start to think about this is it's already a complicated program. We all know then about, and part of the reason why we do information is for everyone to learn. Not, I'm doing this program specifically to hospitals that run the top 1% of, everybody. All of our stuff is free. We do in-person stuff. We do a lot of virtual stuff. But our goal is that if I'm on Medicaid, I understand and I have a place to go and understand this program. If I'm a hospital leader, I can understand this program. If I'm a venture capitalist, and we've seen a couple of really interesting things, and I actually didn't realize Medicaid had a great addressable market and we could make money in this space, I can find a place to go. If I'm a brand new entrepreneur and I'm trying to figure out my MVP and I'd like to help as many people as possible, where do I go to get questions answered? So part of that is that while state and federal dollars are used all the time to improve our Medicaid program, it's very hard to get information. Now you can go to CMS, you can, obviously do a general Google search, but you're not going to see a lot of massive insights, right? It's not kind of a journalistic hotspot. There are some folks who do a great job. There's pieces of philanthropy that do a great job. Colleagues like KFF, like I mentioned earlier, Kaiser Family Foundation and others, the Commonwealth Fund. There's so many people, California Healthcare Foundation, like in the philanthropic space, in the Politico, there is journalistic thinking that is neutral and to give you some great thought, but most of what you'll find is kind of challenging for you to understand where it goes. So we do this information to raise awareness. Now, in the case of something as important as Medicaid redetermination, the reason why we're beating this drum very loudly is it is going to impact the number of people on the Medicaid rolls. Now, we had COVID-19. All of us know this. We've beaten this thing to death. I will just say, being an epidemiologist, nobody knew what the heck that was, and nobody cared. And then all of a sudden I became sexy and important during the pandemic. And it was funny because I was like, well, wait a minute. We had another pandemic in 2003, 2004, which was SARS, but okay. So now everyone actually knows, everyone really kind of knows what this is. We had something called the public health emergency. It allowed us as a nation to put money into services necessary. Lots of things, job creation, retooling and reskilling for workers, helping families, food for Americans, school lunches being paid for, like lots of money that went into helping Americans get through COVID, right? It could be, masks and materials that were paid, public health, undergirding, right? All of these things that were paid for by this emergency state we were in. We were not only a state of emergency federally, but many states were also in an emergency as well. Some were not. That's how some were open and others were not. So there was a bolus of money that came with that. That money is starting to dry up. So the public health emergency has now officially ended. That ended in May, middle of May. But as of April 1st, there was an unwinding of Medicaid. And that means that since the public health emergency came to be, which was, I think, April of 2020, so it's like almost, 3 years, April 1st of 2023, we basically let people on the Medicaid program, but didn't take them off voluntarily. People could voluntarily take themselves off, but we didn't voluntarily take people off. So we've always been used to people coming on Medicaid and getting off of Medicaid, and there's a churn, right? Mm-hmm. But when you have a stop, right, you have a pool of people, that pool grows. So we grew from about what was 81 to 83 million, up almost 10 million additional people in this country on Medicaid. We now are seeing that come down, but we're seeing that come down when for 3 years, the conditions have changed, right? How we communicate changed, how we work changed. I mean, how many people do you know work from home now or don't go into an office or moved or, so there's a lot of a reason why thinking about the lifeline to care for many people, because if you don't have Medicaid, you're likely having no insurance, right? So, because people who are employed have employer insurance, some people have self-insurance, some people go through the exchange, but you either have coverage or you don't have coverage. And what we're worried about is most people getting kind of removed from Medicaid. I'm going to use better terms than kicked off, but removed from Medicaid and then have nowhere else to go. And so then they are increasing the number of people that are uninsured in this country. And so because of that, the sunsetting of the public health emergency created an ecosystem now where people can go through that churn process, get on to Medicaid, qualify, or if they don't qualify or don't prove that they qualify. And so that number, the over 600,000 people since just April 1st, right? So we're only talking 60 days, right? And
there's another 12 months, right? Because isn't redetermination
process so we have about 60 more months to go.
60 more months. Okay.
Yeah. Of this redetermination period. Now,
Sure.
There is money going to states right now. It's being reduced from what it used to be. And it's a step down money process that ends in December. So there's a lot of states really incentivized to get this cleaned up. Now we have different kinds of states. Some states have an MCO structure, some do not. Right. And so an MCO structure is a managed care organization structure, which means that the state contracts with managed care organizations to manage this for them. And there are other states that don't. So every state, we're looking at what are the plans. We want to know what the outreach is. We want to know how this is impacting people. But for folks like us at Health Tech for Medicaid, where we care about health equity and we care about disparities in health, having more people completely uninsured is problematic and concerning. But of that 650, or so people that have dropped since April 1st, the majority of who they are really fall into people that didn't meet the qualification of turning in information. So that is also concerning, right? Because what does that mean if you've lost information or you don't have the information and so that to me says something about outreach. And that's the reason why we are continually talking about this in the many different ways that people want to know about Medicaid redetermination, because it's not something that's on the nightly news. In fact, many people don't know, and many people on Medicaid don't know.
Mm-hmm.
So that's part of the reason why we feel like it's a part of our mission to really keep beating the drum. And we've started with, community-based strategies. We've had a couple of webinars. The last one really focused on the LTSS population, which was super interesting. The next one, we've got kind of a little bit more of that continuation because we got so many questions about LTSS and what does this mean for older adults. We'll do a little bit more of LTSS and some more. Then we've got what does this mean for information systems, and we'll keep responding to what people want to know. But that's essentially one of our biggest issues right now, is just creating awareness. What does this mean for entrepreneurs, right? What does this mean for health systems, right? That potentially have lost a lot of money during COVID. And now we're going to have a huge bolus of people coming in who don't have insurance, right? What does this mean for payers? It's payers' number one issue, I would imagine, in this country, making sure they retain people into their systems and then improving their health, right? What does this mean for policymakers and regulators, right? And I think that's why that there's some attention paid and why we actually know information. But it's also, we were able to change policy with this. One of the things we were able to change is the ability to communicate with Medicaid members by text message. Actually, before December, we weren't even able to communicate with Medicaid members by text. We were only able to communicate with them by snail mail, which I don't know about you, but I rarely even open half my mail. So that's a good example of how times have changed just in the last 3 years. And what does this mean for folks?
That's great progress. I mean, just on the texting front versus the snail mail that you mentioned, Adamika. One question that I think is, I don't know, just kind of nagging at me. I'd love to hear your response on it. I think I know what the answer is, but I don't want to presume anything. What's interesting is I feel like, why is the burden of proof on the Medicaid participant when, and for those of you that don't know, right, the application process is, in order to get enrolled in Medicaid, it's typically financial based, right? It's asset and income based, at least for LTSS. For non-LTSS, it might be just income. Is that right, Adamika?
It's income and asset based across the country, just basically. But each state may have different requirements of what
sure.
that is. Yeah.
Yeah, and that's what's interesting. The government has all of our information. Right? I mean, we're filing taxes on an annual basis. I mean, a big question is, why is the burden of proof on the participant? Why can't why can't the state government just aggregate that information and just keep you on if you're eligible?
Okay, so I'm going to give you the political answer first, and then I'll tell you, or I'm going to give you the, diplomatic answer first, and tell you why it typically falls on the participant. But the burden of proof really lies with the Medicaid participant, and it's crucial for them to seek guidance and support to ensure that they're accurate and complete documentation to establish eligibility and access it, like the services they actually need, right? There are some people who need different sorts of services, and to request those services when they apply. It's the responsibility of the individual seeking assistance. And they have to have the necessary documentation and evidence to demonstrate their eligibility and their need. So part of it is because each state has its own set of eligibility criteria and guidelines, right? And so they most often include income limits, asset requirements, and specific health conditions. So sometimes you can have a health condition that, irrespective of your income and your assets, will allow you to be on Medicaid, right?
Yeah.
Most Medicaid, like when you're applying for Medicaid, most people have to provide documentation of proof of income, their identification of who they are, their citizenship or immigration status. Now, there are states that allow for immigrants to be on Medicaid. California is one, but and then there are the state requirements, right? But for federal, that's kind of what you need to show, right? So in the case of California, they wouldn't meet federal clearance, but they meet state clearance. So the state then pays for their whole Medicaid program versus, does that make sense?
Mm-hmm. Mm-hmm.
But it is the individual's responsibility. Now, it also is important for them to prove that they need additional services or certain services covered by Medicaid. And that could be their medical records, prescriptions, doctor recommendations, or other supporting documentation. Now, I say all that to just basically indicate, because some people, for instance, let's just say autism, right? There's severity levels of autism, right? And so some people need auditory and speech therapy. Some people need assistive devices. Some people need aids. There's all sorts of ranges that come with disease state. You're asking a question that has boggled me from the very, very beginning, which is why don't we have just basic vaccine documentation cards in this country, right? Like, I don't know about you, but I still have a file cabinet with a paper card on it for my family. Now, because of COVID, we were able to do some digital, at least I was in a state that allowed me to have my digital vaccines on my phone. But in some cases, it was only COVID, not all the rest of them. So for instance, I just went to a country that required me to have a yellow fever vaccine. Well, I've had several of them. I used to work for the Centers for Disease Control, right? But if I don't have proof, meaning my actual yellow card, or what they're used to as proof, then I have to get the daggum vaccine again. So there's all sorts of ways in which our healthcare system could be better. And I would say our healthcare and wellness system, just our health system, just health, right? Because the basics of health. And I think that's why an organization like Health Tech for Medicaid is helpful, right? Really to just point out some of these basic flaws that we often don't think about. You're running a hospital all day long. You don't think about these sorts of problems. But somebody like me beating the drum to say, hey, wait a minute. I don't know if you, but at Vive, Anish Chopra and myself did some work, right? Really talking about how do we take things and sync for social needs? We talk all about like SDOH, right? Which is this fancy term, but for public health leaders, we've been talking about social determinants of health for over 100 years. And for me as a public health professional, it's not just social determinants of health, it's political, economic, environmental, ecological, like all of these determinants of health. What we know, or what this actually boils down and means, is that 80% of things like are not having to do with my genetics and who I am, right? It's environment and all of these other, access to my education, where I live, where I pray, where I work, what kind of work I do, that impacts my actual health, right? And so we have things right now where they're trying to determine how to help people who are food insecure. We have no national standard on what food insecurity is. right? And so what happens there is that, we take meetings. There was a very big meeting at the White House in September, specifically. It was the first time in 50 years, all of the nutrition folks kind of came together, and we really decided, like, wow, food is still a very big issue in this country, and people need to eat, right? That's from lobbyists to healthcare providers to agriculture to businesses, right? And so that frame came together. And then out of that meeting, it was like, okay, in healthcare, what are we going to do about this? Well, we need some standards. How can those standards be built into our EHRs, right? Who decides those standards? So these are discussions that literally are happening right now in this country. And so to me, and I'm a fixer, I'm a problem solver. I think I've always kind of been that way, but I'm a really big systems thinker. So that's the reason why Health Tech for Medicaid can poke holes in the system and help come together so we can start to come up with some solutions. So for some people, that could be technology, right? I just gave you a great example, which was like a digital vaccine card, right? A digital insurance card, a great way and I think that these are issues that states are grappling with every day. Now, just remember that every industry has its challenges across this country. And, as a country, like, look at the headlines from yesterday. We finally got a debt ceiling bill passed, but so there's really big issues going on in this country and really teeny tiny small issues coming in this country. But I believe in the power of individuals helping to solve problems in this country that can save lots of people's lives, which is why one of the pieces of news that came out yesterday is Dr. Mandy Cohen may be our next CDC director. And, a great friend of Health Tech for Medicaid. She knows Medicaid deeply. She ran Medicaid in North Carolina, also had time in DC. I think she's a great person who will be. So some of it is just getting alignment and having people come together and say, this is crazy. We don't have, look, in many cases, we don't even sync between Medicaid and TANF or SNAP benefits, right? Right? So even just basic services we could be doing. And some of that may have to start at a state level. And there's some states that are very interested in getting their data systems together. But even the basics, right? Can we get websites in things more than English, or with people that are deaf or blind or have tactile disabilities? Can they actually get information? So, lots of problems to solve. And the way that I look at it is lots of opportunities and ways for us to come together to create solutions to improve. And that's an iterative process.
Totally agree.
This technology is that worked here. I'll give you a great example. When I went to college, I didn't have a computer. Why? Because we didn't use computers like that. They were not personal computers, right? I went to college with a suitcase looking thing that was a word processor that I plugged into the wall, right? Now I'm giving my age a little bit here, but there was no email, right? So we continually grow and learn and move. And now I have got a 13-year-old who's, trying to tell me about how ChatGPT can help me improve my we move leaps and bounds, but we often don't bring the community along with us. So for things like ChatGPT, I think about, who's talking to the community about artificial intelligence? Mm-hmm. What does it actually mean to people? What is AI? Are we talking to folks about what this means? And so when I go talk to entrepreneurs, they're like, yes, I have an AI enabled, but that's great. But if we don't figure out how to bring folks along with us, that's really the goal, is how do we equitably and inclusively design our products, our services, our delivery systems, our capital markets, and narratively change this. And that means working with, and for the community, right? And that, I think, is the answer. I think that's the thing I've learned the most. What made me a great hospital leader was not, just that I did math well and I had decent people skills and I liked folks. It was that I took the elevator every day and I could hear in a, just few minute ride how hard it was to park, what the soup was for the day. Man, this doctor was really rude. This was a really important front desk person. I got off the elevator and 12 problems could raise themselves, and 6 abilities for me to recognize people could also raise themselves. sometimes it's the basics that we forget, and we get mired in the business needs without really bringing folks along with us. So that's kind of our goal.
And Adamika, you mentioned earlier, I mean, I guess throughout the conversation, you've touched on population health. And I mean, one of the things that jumps out to me too, at least according to the most recent Kaiser Family Foundation report that I saw, that measures like the U.S. triple aim and how we're performing against other developed nations. I mean, in terms of like the insured rate, at least the last time I saw it, it was like 90% of Americans have insurance. And of, the other 13 developed nations on the list are like 99.7% or greater, or something along those lines. You had mentioned, and I know we were texting, several weeks ago about you were traveling within New Zealand and Australia, Singapore, et cetera.
Sure.
And was there anything that you took away from there? Because it's just so interesting that they've got higher insured rates. What are they doing there that maybe could be applicable here?
I mean, all of those. So I was on a delegation with a group, a handful of Americans going to study health equity in Australia, New Zealand, and Singapore in April. And what I will say from that visit is we were really focused on health equity, right? A wide swath of clinical, non-clinical folks in systems, in philanthropy, in associations, kind of in that group. One of the things that to those countries specifically, and most of the developed world, they have a government payer system, right? And essentially, I guess we have a government payer system as well, but it's very fragmented, right? And so, and these are countries, it's hard to compare the US to a lot of places, let's be real, right? Like New Zealand's population is 5 million, right? Australia, while as big as the US, literally physically in size, maybe just a little bit smaller, not much. There's only 25 million people that live there, right? And Singapore is a little teeny island that has built up significantly over the last 50 years from a hold of, but it's also like a 5 million, population, maybe plus or minus a few. So it's hard to like compare, right? Like, and I'm mindful of that. I've done international work in my career. I think a lot of the principles that we have at Health Tech for Medicaid, we're called Health Tech for Medicaid, but theoretically we can't call this like Health Tech for all or Health Tech for the world or Health Tech for, everyone, because then you can't actually quantify it. The reason why we're Health Tech for Medicaid is really about vulnerable or underlooked populations and how do we get technology into them, because those are the places where we don't have technology today. But the principles are really universal globally, right? And we are kind of participating more in the global scene as we've gotten older as an organization. I mean, we literally just turned 5 this year in November. So
congrats.
We're still learning.
Yeah.
We're still in our infancy as a nonprofit organization in this country. Sure. I will say this much. There is a large focus on the health of the populations in the many countries we saw, meaning that I think folks really understand that if their residents and citizens are not healthy, they can't contribute on a global scale. That requires us to have a shift in thinking, right, in the US. And I think some of that is just our growth and evolution as a country. I also think all of those countries are a bit unique. Maybe 2 of them are a bit unique, and that they've acknowledged their past harms in this country or in their country that they live in. And I think that goes a long way in everyone feeling like they are an American. Now, to be fair, there's a lot of people who choose to come to America. That's actually how this country was ballooned in size, but there were people who were native here, right? And there were people who were forcibly brought here. Lots of different populations of people, shockingly, if you really know U.S. history, right? There were forcibly brought here to this country. That makes for having to really think about how we acknowledge our past harms, how we acknowledge our history, and how we move ahead. And just coming off the heels of Memorial Day, and I was with I have 2 boys. We were in North Carolina, kind of doing an exploration trip, which was a lot of fun. And my older son is getting ready to go into 8th grade, right? He can now call himself an 8th grader because they're on summer break. But that is really where most of the U.S. children learn about U.S. history. And we still are at a place in this country where, depending on where you live, what kind of history you get. And we're grappling with a lot of those issues in this country right now, which diminishes the noise around some of the other things. It's also, I don't think anybody will deny that we're in an interesting political conundrum that is getting in the way, I think, of our country being as great as it could be. I always like to boil things down to something as basic as most of us want to live, right? And so health is really one of the number one voting issues. And red states, blue states, purple states, all the states alike, when health comes up on the ballot, most people really want to live and stay here, right? And so that's why we're a nonprofit. We're really nonpartisan. We do advocacy to really improve everyone's health. And I think that there's a couple of ways you can do that really well. We push for data. I think having disaggregated data really tells us where there are problems and where we can create innovative solutions, whether those be tech-enabled or not. Another is really transparency of information, right? And the third is really a dialogue, really being able to ask questions and figure out how you can be a part of a solution set in fixing or changing, whether you're insured or not, the outer fabric of all of us being healthy in this country. Because health itself doesn't necessarily only have to do with access to medical services. I would hope it should, and this developed of a nation, I'll leave that aside. But we have many places in this country where they don't even have drinking water or trash pickup, right? So the basic undergirded, like a public health ecosystem we're working on. And I think that is what COVID helped other people to realize. And so I hope we use this as a springboard to really move together as a nation. And we hope Health Tech for Medicaid is a part of that solution set.
Adamika, I've got one more question for you about what you're most excited about in the future. But before I get there, I want to touch on Kevin's question in the comments. I think we've touched on all of their comments just through the natural progression of the conversation. But and I know you have mentioned in past conversations that you've got RCM experience. Anything specific on the RAC audit side?
Yeah, so a RAC audit, for people who don't know, is a recovery audit contractor. That's what the RAC stands for, RAC. And that is really a process that CMS, or the Center for Medicare and Medicaid Services, use to identify and recover improper payments. So I always like to dispel myths a little bit. There is a large bolus of money we spend in this country on what we call fraud, waste, and abuse. And if we could bring that down, we can use some of that money, right, to do more innovative things. I don't try to spend as much time in the fraud, waste, and abuse side, because a lot of it is and there's lots of places to get information on that. And there are lots of consultants who spend lots of time on that. I find that distracts us a bit from the general ethos of where we sit at Health Tech for Medicaid, which is really to, kind of use technology, where health equity and tech equity kind of come together. But I do think that there's exciting technologies out there that kind of look at a couple of, the basic RAC audit process is in a couple of steps, right? So if you think about a RAC audit, if you're on the healthcare side, you know this deeply. They look at kind of your medical records and your billing documentation to see if there's been incorrect payments, billing errors, or fraud or abuse, right? And so they look at overpayments and underpayments, really made to pretty much healthcare providers, right? So you typically see this in hospitals, physicians, other healthcare facilities. And I'm literally on the heels of just speaking at the American Physician Groups Conference. So this is very near and dear to conversations that have come up today. So what I would say to that is a RAC, the RAC ecosystem falls in kind of 5 steps. And those are data. You have to have the good data. So I think that's what we really push for, is having data analytics really helps us in not only what claims people have, that helps us figure out what people need. So that's something we would advocate for deeply. Medical record reviews are done in RACs, claim determination, and that's between the payer and the provider. Then there's typically an audit that happens with RAC, and then there's an appeals process. And what I would say to people who are really new to this terminology is that a RAC audit is to ensure that there is program integrity and prevent improper payments And so therefore shows the American people that there's a safeguarding mechanism, right, for the Medicaid program and the Medicare program. It's actually CMS total. So Medicare and Medicaid, so Medicare is about, Medicaid is about 91.5 million people, plus or minus a few. There are, like I said, dual eligibles. Medicare is another bolus of folks. So I hope that answers the question about RAC specifically.
Thanks, Adam.
I could try to break that down in 4 minutes.
Thanks for doing that.
What I will say is that that is also another benefit of Health Tech for Medicaid, is the deep Medicaid insight and knowledge that we have access to, and our broad out ecosystem. We don't have the answer, somebody will. And we kick the tires on lots of things and get people's perspectives on what works. And then we wrap that up and give people findings and kind of go from there as well. So on the revenue cycle of CMS, there's a lot of safeguards and protections to make sure that this taxpayer dollar that is going in is being utilized correctly. And you're right. The more waste, fraud, and abuse we can reduce, the more money we can actually use to improve care.
Love it. And last question for you, Adamika. I know we're running short on time here. What are you most excited about in the future?
Oh, I'm excited for so many things. I'm an eternal optimist, so I'm always excited. I'm excited this is graduation season, so maybe a bit of young folks learning more. I would say the younger generation interrogates and asks lots of questions. And so that's exciting to me, just having young voices really learning and thinking and being a part of our ecosystem and thought leadership. I'm equally as excited about pushes in this country around health equity. I've been really pleased with this administration to really tackle and address very big issues, despite some of our political underpinnings as it pertains to things like abortion and other trans rights and rights. I mean, it's pride, and yet we have all this acrimonious challenging. But I actually think that that's the productive tension that happens in really good discourse in a democratic society. So I am always pleased and interested to have many different voices around the room. I actually think that's actually how we solve problems. And I would say that the other thing that I am, we have great people doing incredible work in this country. And I think that that pandemic did level set for most Americans and kind of being interested in their health. So I'm hoping that if their health is a indication of I'm the only person who's on my flights with a mask, I'm a little worried. But because we still are in a pandemic, I will remind people. But I just think that I believe in the tenacity and hope of America and Americans. And I really think that we're a young country. We are going through some very interesting growing pains as a country. And I think we're going to come out on the other side of it a better nation, a better partner in international relations. And equally, I hope to see us really investing more in health and where health care kind of intersects with that. So the horizontal and vertical underpinnings of health. And I'm a public health person in my blood by nature, but I also deeply believe in the power of community. And so I see this as a time for our communities to actually start getting outside and getting together again safely, but for us to use our public libraries, our outdoor barbecues, to have conversations, and to allow kind of the loneliness and the challenge of the last few years to kind of melt away, and us to really go back to being citizens who really care about others. And so those deep fundamentals and values, I'm really looking forward to the world opening up in some ways and people getting an opportunity to break bread and despite differences have really productive solutions to solve our world's problems. So I will forever be a person who believes that there's always a better way out.
I love that vision and the optimism. Adamika, thank you so much. It's truly my honor to host you today, and appreciate your time. Know you're very busy, always leave inspired based on every conversation that we have. Recommend for everybody on the call, on the webinar, and future attendees, check out Health Tech for Medicaid site, ht4m.org. Is correct, Adamika?
Yeah. And you can email us at info@ht4m.org. Yeah, we're available to help. We're on Twitter, Instagram, Facebook. We're on the on socials, and then you can also find me and Madam Medicaid. I think I'm on Instagram and Twitter at Madam Medicaid. So always looking forward to having conversations. Love to hear people's stories. I do believe storytelling is a great way for us to level set and think about how we can do things better in this country. But thank you, Michael, for your time. And I look forward to partnering and continuing to hear from others.
Absolutely. Thanks again, Adamika. Enjoy the rest of your day. Appreciate your time. Take care. Bye.